Broadcast is now starting. All attendees are in listen-only mode.
Hello, my name is Kelly Tebow, and I'm with the New Jersey Center for Tourette Syndrome and Associated Disorders. I am your organizer for this evening and would like to welcome you to our webinar on the relationship between TS and autism. Excuse me. Thank you all for joining us. Wow. Before I have my colleague introduce the speaker for tonight, I'm going to cover some housekeeping items with you. All participants are muted. If you have a question, please type it in your question box and click send. You may send as many questions during the webinar. However, we will have Dr. Kurlan answer the questions at the end of his presentation. We will get to as many queries as time allows, and in addition, tonight's presenter is available to take your questions on the Wednesday webinar blog, which is accessed from our homepage under the heading Programs. This blog will be monitored for the next 7 days. Feel free to look and post questions as often as you like. Answers will be archived for future reference. If you missed the part of the presentation or would like to watch it again, an archived version will be posted to our website. We value your input, and in order to expand our webinar experience in the future, we need everyone attending to fill out the survey as you exit the webinar. The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented, nor do we endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now I'm going to turn over the introductions of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Thanks, Kelly. Good evening, everyone, and welcome to our first webinar of the 2018-2019 school year. Before I introduce tonight's presenter, I would like to make an important announcement and mention a couple of upcoming events. In particular, I want to tell you what has been achieved in TS research. Scientists at Rutgers, along with others around the world, are working to unravel the causes of TS. I invite you to visit our website for the latest information. If you would like to participate in the genetics program at Rutgers, please email familystudy@biology.rutgers.edu. Additionally, I'd like to mention that we are holding. One is on October 13th for kids ages 3 and the other one on for kids aged 12. Both programs cognitive degree from the University of Rochester School of Medicine in St. Louis. His postgraduate training was at the University of Rochester Medical Center in Neurology and Movement Disorders. He was a longtime faculty member at the University of Rochester, where he was director of the movement disorders and also the cognitive and behavioral neurology programs. Then he was a director at the movement disorders program at the Atlantic Neuroscience Institute in Summit, New Jersey. He has edited 4 books and published more than 250 articles. He is recognized internationally for his clinical skills and research in neurological, cognitive, behavioral, and movement disorders. He's collaborated with many neuroscientists and has conducted many large-scale, multi-center research studies. He led an NIH-funded multi-center trial of the Alzheimer's Disease Cooperative Study Group. He's also a founding member of the Parkinson's Study Group and of the Tourette Syndrome Study Group. Dr. Kurlan, welcome back. Now, without further introduction, I'll turn tonight's program over to you.
And I appreciate you joining this webinar. My discussion tonight is the relationship. I'm just trying to make more room for the slide. One is that be providing tonight should be considered preliminary. This is an area that is of greatest interest to movement disorders or Tourette syndrome specialists, and like myself, but unfortunately researchers in the area of autism, which is a much larger group, have not paid a lot of attention to the relationship between autism and Tourette syndrome. And you'll see one of my conclusions for tonight is this is an area that needs and deserves a lot more research. Much of the information that is out there about the relationship of Tourette syndrome and autism leads to a key question that has been discussed in the medical literature and also clinically. And the question is whether Tourette syndrome can actually be considered part of the autism spectrum disorder. And that's a question I'm going to try to answer tonight. As some background, I want to give you some working definitions that'll help clarify much of the discussion. When I use the term Tourette syndrome, I'm just referring to the condition that we're all familiar with, the one that's characterized by chronic motor and vocal tics. There are a number of other potential criteria that are used for diagnosing Tourette syndrome, and I'll talk more about those later. But for most of the discussion, I'm just going to use the term Tourette syndrome when we're talking about patients who have chronic motor and vocal tics. Most of you are aware that the term autism has been replaced by a newer terminology, autism spectrum disorder, or ASD, largely because of the recognition that the manifestations of autism are highly variable, and also the severity of the condition is quite variable, ranging from fairly mild to quite severe and disabling. But the main criteria for diagnosing autism spectrum disorder includes the presence of these three main issues that are listed here. One is the presence of impaired social interactions, problems with communicating with other people, and an emotional detachment. And the term autism largely derives from that last characteristic, the problems with emotional detachment. Now, who started and when did we start thinking about the possible relationship between Tourette syndrome and autism? In 1986, in the medical literature was a single case report of a patient who was called the Pinball Wizard. I don't know how many musical experts we have in the audience, but this term Pinball Wizard came from a record album produced by the musical group The Who, and this was a rock opera called Tommy, and the main protagonist in the rock opera was a boy who was called the Deaf, Dumb, and Blind Kid. And as it turned out, rather than actually being deaf, dumb, and blind, he really was more likely to be autistic or perhaps have emotionally induced autistic features. And in 1986, a group of doctors in England described a patient who had a combination of both autistic features and also Tourette syndrome. And by reporting this case, they thought this was a fairly unusual occurrence. And one of the reasons they used the term Pinball Wizard is that some of the autistic qualities of this patient was that he was very good at computer games and pinball and things like that. Over time, it became clear that this was not a rare phenomenon at all, but rather there was a very common co-occurrence between Tourette syndrome and autism. A scientific article in 1991 reported 57 cases who had the combination of both autism and Tourette syndrome. And over time, there have been a number of research studies that have reported prevalence rates. That is, how common is it that patients with autism also has Tourette syndrome or chronic motor and vocal tics. The first articles were published in 1999, and one suggested that 8.1% of patients with autism have tics, and a second one reported 6.5%. And since that time, there have been a number of other studies that have looked at this relationship between Tourette syndrome and autism, and rates as high as 50% have been reported, meaning that half of children with autism actually have motor and vocal tics. The rates have varied somewhat depending on the methods used. For example, some studies of prevalence just looked at information in a medical record, whether both diagnoses of autism and Tourette syndrome were listed, whereas others use more detailed methods such as having trained examiners or experienced examiners actually look and examine the individual patients with autism to see whether or not tics are present. And these differences in methods probably explain the differences in the reported prevalence rates. But nevertheless, I think it's generally accepted that children with autism commonly have motor and vocal tics. Indeed, it's been recognized that there are a number of clinical overlaps between patients with autism and those with Tourette syndrome. I think most of you are probably familiar with the term Tourette syndrome triad. This is a term that is used to describe the common occurrence of the three conditions together: the tics of Tourette syndrome, obsessive compulsive disorder, and ADHD. And it's generally thought that for children with the tics of Tourette syndrome, approximately half will have either or OCD or ADHD. And if one sees a patient with one of these three conditions, it's important to have a high index of suspicion for the other two because they occur together so often. Another clinical overlap is that both Tourette patients and those with autism sometimes display what's called echo phenomenon. And this would be echoing back what other people say, or perhaps echoing or repeating what other people do. The verbal one is echolalia, and the motor movement one is echopraxia. Some people view this as actually a type of a motor or a vocal tic, but the echo phenomenon, the repeating what other people say or do, is something that is seen not uncommonly in both Tourette syndrome and autism. Patients with both conditions often display self-injurious behavior. This would be things like picking at the skin, scratching oneself, poking, banging the head, poking one's eye, or other kind of behaviors that can be potentially self-injurious. Also, both autism and Tourette syndrome are commonly associated with mood and anxiety disorders. The mood disorders include depression or bipolar disorder, and common anxiety disorders in both conditions would include the OCD, generalized anxiety, school-related anxiety, test anxiety, separation anxiety, and a variety of phobias. So mood and anxiety disorders are seen often in both autism and Tourette syndrome. Patients with both conditions often display impulse control problems. These would be things like rage attacks or temper tantrums. It's sometimes said that the patient goes from 0 to 60. They may yell, become impulsive, aggressive, throw things, punch people, hit people, and these impulse control problems are seen in both conditions. Learning disabilities such as reading disorders, verbal processing disorders, things like that are also not uncommonly associated with both autism and Tourette syndrome. And both also, patients with both conditions often display what are called environmental sensitivities. So the children or sometimes the adults are extra sensitive to touch, sound, light. They may be super sensitive when the peas touch the potatoes on their plate, or if a parent speaks with a certain tone of voice that they can't stand. It often sends these kids into rage attacks or makes them aggressive or lose control. I should say that environmental sensitivities does seem to be linked to obsessive compulsive disorder. Children with OCD often do have these environmental sensitivities. So this might be the explanation for why the sensitivities are commonly seen in both autistic and Tourette patients. But taken together, there's a lot of clinical overlaps, and given the fact that they occur so commonly together, it has led to the question of whether Tourette syndrome might be related or in fact be a subtype or part of the autism spectrum disorder. There are also some common environmental factors between the two conditions. Statistically, it has been found that children with Tourette syndrome and autism tend to come from a lower socioeconomic group, although they occur commonly in all socioeconomic groups, but there's a statistical association compared to control children who don't have either condition to the lower status. Both conditions seem to be associated with prenatal stresses such as early labor and delivery, infections in the womb, loss of oxygenation during the birth process, and prenatal stresses do seem to increase the risk of both autism and Tourette syndrome. The role or a potential role of immune responses has also been brought up for both Tourette syndrome and autism, including such things as allergies, environmental allergies, food allergies, gluten sensitivity. These sorts of things have been brought up as possible risk factors for both conditions. In research studies, some children with autism and some with Tourette syndrome display some abnormalities on the immune testing, but the significance is largely unknown. Whether it is related to the etiology or not is unclear. And then both conditions have been reported to have, in some patients, usually small numbers of patients, potentially abnormal immune responses to infections. And so streptococcal infection, for example, has been brought up as part of the PANDAS process related to Tourette syndrome. But there's a much older literature that at one time suggested that streptococcal infections can also lead to autism. That research is about 20 plus years old and preceded the potential link between strep and Tourette syndrome. That has largely been disproven, and the link to Tourette syndrome is largely disproven as well. But both conditions, potential abnormal immune responses to common infections has been raised. Also, you probably know that there has been a long tradition of ascribing the development of autism to immune vaccinations that children receive. And the vast majority of scientific studies have disproven any relationship between vaccinations and autism. But it's curious how both Tourette syndrome and autism have had similar discussions about these immune factors. In addition to the many clinical similarities, there are some clinical differences which may make it a little less likely that Tourette syndrome is in fact part of the spectrum of autism. The age at onset is usually quite different. It's now said that most children on the autism spectrum can be recognized or at least preliminarily diagnosed by the age of 18 months. But for Tourette syndrome, the mean age for the first appearance of tics is about age 7. So the age at onset tends to be quite different. Children with autism spectrum disorder often has a certain type of involuntary movement called stereotypies, which are typically not present in children with Tourette syndrome. Stereotypies are movements or noises that are repeated over and over and over again for periods of minutes, if not hours. Examples might be rocking of the body, rocking of the head, finger flapping, humming noises. And compared to tics, these tend to be much more stereotyped. That is, it's the same movement over and over again. That's where the term stereotypies came from. And also compared to tics, they tend to go on and on for a very long period of time. And stereotypies are typically not seen in children with Tourette syndrome. One question that has never really been addressed in research and should be is the question of whether the qualities of the tics differ in Tourette syndrome and autism. So we know that both conditions commonly have tics, but are the qualities different? So for example, in Tourette syndrome, we know that the characteristic feature of tics is to wax and wane over time, meaning there's a period of weeks or a few months where they're worse, and a period of weeks or a few months when they're better. We generally think that this is not related to environmental factors, but more the intrinsic imbalances of the neurochemicals in the brain that fluctuate over time. No one has really studied whether the tics in autism also wax and wane. Another characteristic of the tics in Tourette syndrome is that they tend to change types over time. So there tends to be a group of a few tics. They're present for some period of months, and then often they change and they're replaced by a completely different group. There may be one or two tics that persist, but the changing of tic types is a characteristic of Tourette syndrome tics. And it's never really been studied whether a similar change in types occur in patients with autism. Another unknown is about the natural history of tics. Fortunately, in Tourette syndrome, most children do experience some improvement in the severity of tics, generally after about the age of 10 to 12 years old, with about 2 out of 3 children either having a significant improvement in their tics or a complete resolution by the time they become adults. So the outlook is fairly good in Tourette syndrome. In autism, however, there has not really been any natural history studies of the tics. It's unknown what the course is over time, whether the same improvement is present that's typical of Tourette syndrome. In fact, there's some case reports of the opposite, meaning that some children with autism during their teenage years or later in life may experience a clinical regression where various aspects of their autism decline and they get worse. This typically does not happen in the tics associated with Tourette syndrome, especially in adults or older teenagers. Another question or issue is that most Tourette patients do not have the social, emotional, or communication problems seen in autism. So if these are considered the sine qua nons, the requirements for the diagnosis of autism, it would actually be very difficult to suggest that most children with Tourette syndrome actually fall on the autism spectrum. Because of the co-occurrence and the many common similarities between autism and Tourette syndrome, there has been some work and reports in the literature about possible common mechanisms, common neurobiological, developmental, or brain mechanisms that might explain why they do occur together commonly. The first one was proposed back in the 1970s, and one researcher suggested that there was a certain gene called tryptophan oxygenase that was abnormal in both conditions. This is a gene that makes sense because it's the main gene involved in the production of a certain neurochemical in the brain called serotonin. And you probably know that serotonin is a chemical that's thought to be imbalanced in individuals who have obsessive compulsive disorder, OCD. And since OCD is common in both Tourette syndrome and autism, it could be one overlap mechanism. Subsequent research has not really established this to be true. It has not been confirmed. Another researcher in about the 1980s suggested that there is an abnormal gene for Tourette syndrome, which is the explanation of why the condition is often passed from generation to generation. But they went on to suggest that in Tourette syndrome there is a single copy of this gene, but that in autism the individual has two copies of the Tourette syndrome gene, something that's called homozygosity. So these individuals would have a double dose of whatever the biochemical problem was, and this researcher suggested that Tourette syndrome is in fact just a milder case of autism, or the other way around. Autism is just a severe form of Tourette syndrome that's more severe and has more problems. One thing that has been fairly consistent is that fairly consistent research indicates that the same brain regions seem to be involved in both Tourette syndrome and autism. And this is an area called the frontostriatal pathways. These are the pathways from the frontal lobes into deeper part of the brain called the basal ganglia. The striatum is one of the portions of the basal ganglia. And this is a pathway that we now understand is very much involved in motor control. So it makes sense that an abnormality here might lead to involuntary movements like tics or stereotypies. It also seems to be involved in the control of thoughts and as well as attention. So again, it makes sense that this same brain region, if it's affected during development, may lead to not just involuntary movements, but also things like obsessive compulsive disorder or attention deficit hyperactivity disorder, ADHD. It's now recognized that tics are seen fairly common in the relatives of patients with autism spectrum disorder. And this is additional pieces of information to suggest that there is a genetic component that coexists with tics and autism. There is a condition called a rare copy number variant that seems to be abnormal in both autism and Tourette syndrome. And what this refers to is that many individuals have more than one or sometimes multiple copies of certain genes. And it looks like some of the genes that are involved have an increased number of these copies, an abnormally increased number in patients who have been studied who have both autism and Tourette syndrome. And some of the genes that have the rare copy number variants are the same. And they represent this last bullet point, is that they seem to have shared genes to some extent, not necessarily identical genes, but genes that are involved in the same processes. And the two processes that stand out for both conditions is, one is synapse formation, and synapses is the region where brain cells communicate with each other, where the brain cells come together. And the formation of these synapses or the connections is a very key part of brain development. And so it would make sense if there's a genetic disorder of synapse formation, it might underlie both Tourette syndrome and autism. A second mechanism that seems common where the genes are involved relate to the balance between what's called excitatory and inhibitory neurotransmitters or neurochemicals. And these are chemicals that are used in the communication between brain cells. So some of the chemicals will excite the next nerve cell in line and others will inhibit the next one. And as you might expect, the critical balance of these excitatory and inhibitory neurotransmitters, neurochemicals, is highly important in normal brain function. And so an imbalance, it's reasonable to think potentially could lead to Tourette syndrome or autism. I wanted to just mention some of our own research that bears on the question of whether these conditions are related. About a year ago, we did a research study where we examined and interviewed about 40 children who have autism spectrum disorder. We examined them and we divided them into 3 groups. One was a group of children with autism and tics. Another group had autism with the other kind of involuntary movements, stereotypies, but not tics. And then there was a third group that had autism alone and they had no evidence of tics or stereotypies. And what we did find is that the group with autism associated with tics seemed to have a completely different genetic pattern than the other 2 types, the group with stereotypies or the ones with autism alone. So again, our own research does support there are similarities in the genetic makeup of these children, but also some differences. I just wanted to mention some treatment issues that might come up. Some people have asked if the tics associated with autism respond differently to treatment than the tics associated with Tourette syndrome. We have observed some mild differences. One is that tics in both conditions can respond to the same medications. So the usual medicines that are used to treat the tics of Tourette syndrome, like guanfacine or clonidine or some of the antipsychotic neuroleptic medicines, can suppress tics both in Tourette syndrome and also autism. There's some evidence that some of the behavioral treatments like habit reversal treatment for tics may be less effective in autism, probably because there may be cognitive problems in children with autism, so they may not be able to cooperate with or perform the cognitive behavioral type of approaches, as well as children with Tourette syndrome who traditionally do not have cognitive problems. It does appear that the tics in autism and also some other conditions in which tics occur other than Tourette syndrome, things like drug-induced tics or tics associated with encephalitis or head trauma. These secondary conditions are called Touretteisms. In general, they may be less predictably responsive to the usual medications than the tics associated with Tourette syndrome that tend to improve fairly responsively and predictably. It's unknown whether the responsiveness to medications or cognitive behavioral therapies are different when associated with autism spectrum disorder, things like OCD or ADHD. But generally, most clinicians do think children with autism are somewhat less responsive in these conditions when they do occur in the setting of autism. And again, it may just be there are cognitive problems or more difficulties superimposed on the tics or OCD that complicate the response to treatment. I did want to mention some issues that come up when we address the question of could Tourette syndrome be considered part of the autism spectrum disorder? Well, most of you are familiar with the book called the Diagnostic and Statistical Manual of Psychiatry, or DSM. And this is so-called Bible for diagnosing neuropsychiatric disorders. And there is a criteria for Tourette's disorder or Tourette syndrome that says you cannot use the diagnosis of Tourette syndrome if the tics are attributable to another medical condition. So if the tics occur in the setting of autism, one might say, well, they are attributable to the autism. And DSM would in this case prevent the use of the term Tourette syndrome in a child with autism. So I have a number of patients sent to me who carry the diagnoses of both autism spectrum disorder and Tourette syndrome. And at least technically speaking, these are diagnoses that are largely mutually exclusive. As I mentioned, there's a term called Touretteism, something resembling Tourette syndrome, that is considered a secondary form of tics, whereas Tourette syndrome is considered the primary cause of tics. So in addition to autism, I mentioned some other secondary forms like drug-induced tics, other neurological disorders like Huntington's disease, encephalitis, head trauma, and some other conditions can induce tics. Another classification issue would be that current requirements, current criteria for diagnosing autism spectrum disorder actually requires the presence of deficits in social interactions, communication, and emotions. And so most patients with Tourette syndrome do not have these features. And so technically, using most published criteria, one could not use the diagnosis of autism spectrum disorder in the absence of these characteristics of the diagnosis. These are some conclusions I just wanted to end with. It's pretty clear that Tourette syndrome and autism spectrum disorder share a large number of clinical features. There's a lot of clinical overlaps. It does look like there's a possibility that there could be a certain subtype of autism, something that has been referred to as the basal ganglia or frontal basal ganglia subtype. And these are children with autism whose clinical picture is dominated by involuntary movements like tics or stereotypies. And so this is a subtype of autism that could be the one that closely resembles autism itself. Interestingly, other subtypes of autism have been suggested. For example, a cortical subtype. These are autistic children who have intellectual dysfunction, often seizures, and often abnormal EEGs. Some have suggested an autonomic subtype of autism where there are problems with digestion, blood pressure, heart function, etc., and an occipital form of autism spectrum disorder that's dominated by problems with visual processing. These individuals often have abnormal spikes in the occipital or the back part of the brain on their EEG. So it's possible the overlap that's been discussed between Tourette syndrome and Tourette's and autism might reflect this potential subtype, the frontal basal ganglia subtype of autism. There clearly are genetic similarities and also differences, and genetics will probably turn out to be a key area in helping us sort out the question of whether Tourette syndrome is indeed closely related to autism. It does look like synaptic formation and the balance between inhibitory and excitatory neurotransmitters are common abnormalities in both conditions. So there may be similarities even though they may not be exactly the same illness or condition. It's clear, I think, that a better understanding of autism or Tourette syndrome will likely better inform our understanding of the other condition because they are so similar. And I'll end there, and I'm happy to take questions. Thank you.
Okay, thank you very much. There's a lot of great information there, and we actually have quite a few questions. So I'm going to launch right into those. First off, how do you determine what is a tic and what is self-stimulatory behavior in a child who has both diagnoses?
Sure, that's a good question. Most experts in the field of movement disorders, like myself, do not use the term self-stimulatory behaviors. Some people have called it stims. That term implies that one knows why the child is engaged in the repetitive abnormal movements. It's been hypothesized that the movements like the finger movements or the head shaking or the body rocking are mechanisms to induce an internal form of stimulation, but nobody really knows that this is true. Some have suggested, in fact, the opposite, that these repetitive movements are a way of trying to block out other aspects of the environment which are too difficult for the autistic child to deal with. And so terms like stimming or self-stimulation behavior or stims generally isn't used. Movement disorders specialists will rather than focus on the potential cause or basis of the movements for actually describing the characteristics of the movements in detail. So stereotypies, which would be the movement disorder term for the self-stimulatory behavior, represent movements that are highly repetitive, the same movement over and over and over again for quite a long period of time. Differs quite a bit from tics typically. In tic, to really last more than a minute or motor than a vocal or than a motor. They're not nearly as stereotyped as those stereotypies.
Okay, so a follow-up question to that. Would, so that's one movement related, distinguished as an autistic move. Would that child then also have a tic on top of that, or do they seem to occur at separate times?
It's different. So many children with autism have both stereotypies and tics simultaneously or sequentially. And sometimes it is hard to distinguish. The movements can be complicated, especially when they're occurring at the same time. But tics and stereotypies can occur simultaneously. So for example, an autistic child may rock back and forth for several minutes, and during the rocking they may have a vocal tic, like a whoo or a sniff. And so this would be a child engaging in a stereotypy, but superimposed on the stereotypy would be a motor or a vocal tic.
So distinguishing them, you would kind of fall into the categories then of what's a typical tic and what's what you might classify a typical ASD movement?
Yeah, based on people with experience, it's fairly easy to distinguish them. Like I said, it almost never does a tic go on for 5, 10, 15 minutes, an hour. Whereas rocking movements, vocal stereotypies like humming, finger wiggling in front of a light, for example, those are stereotypies that occur in autism that can go on and on and on for several minutes at a time with no interruption.
Okay. All right. Thank you. So another question. Often with TS, OCD can be quite disruptive. Does it produce the same disturbance in kids with ASD, or does it present in a different way?
No, it's actually very similar, but one has to just know the right questions to ask. So very typical obsessions and compulsions that are seen in primary OCD or Tourette syndrome are seen in children with autism. Some of the classic ones would be things like repetitive hand washing, checking compulsions, checking to be sure the toys are put away properly or that the door has been locked, obsessing about whether mom's or dad's going to come home safely, compulsions like you have to knock 3 times on a doorway before you can go through it. These sorts of things are extremely common in children with the autism spectrum disorder, and one has to just really carefully inquire about it. And a lot of clinicians unfortunately don't really think about OCD. They kind of focus on the general problems with autism, but it is important to really dissect the symptoms out. And if one does that, it's extremely common to find OCD in children with autism. And it is very important to make the diagnosis because the OCD often does respond to standard medications used to treat OCD. And it can make a huge difference in terms of behavior.
Sure, sure. Okay, so I think you're probably, or most people are who are familiar with TS and the co-occurring disorders. You know, you've seen those diagrams where all the circles intersect: OCD, ADHD, anxiety, and kind of TS is kind of in the middle of all of those circles. So the question being posed has to do with those circles. So considering the comorbid disorders with Tourette, would autism be, is it possible for autism to be somewhere in that circle when you look at the circles that intersect to, you know, create the Tourette piece?
Yes, that's exactly what has been suggested as a possibility, that autism spectrum disorder would be a circle in that diagram that also interacts or overlaps with Tourette syndrome, OCD, ADHD, mood and anxiety disorders, etc. Meaning that some children with the autism spectrum have tics, and those would be the ones where the circles overlap. And then there are other children with autism spectrum disorder who don't have tics, but they may overlap with the OCD, the ADHD, the mood disorder, the impulse control disorder, etc. So most of these conditions are considered spectrum disorders. So even Tourette syndrome itself is considered a spectrum disorder now because of the common comorbidity with OCD and ADHD. And some have suggested that other things should be part of the spectrum, like learning disabilities, mood and behavioral disorders, impulse control problems, etc.
That's quite a bucket when you put all those.
Yeah, it's hard to get the circles just right.
Yeah. Okay. I have a question. How does one do immune testing?
The immune testing that I mentioned is largely not clinical. It's not the type of test that a traditional doctor would do, but they're more research types of immune tests. And you know, some of them have been used in, people have probably heard of the research on pandas, the hypothesis that some patients with Tourette syndrome or OCD, it might be an autoimmune disease related to strep infection. And some of the researchers have taken blood from patients possibly having the pandas condition. And compared to some normals, they have described some immune abnormalities or differences. But generally they're not immune tests that a traditional doctor would do. They're not generally available outside of research.
So someone would perhaps have to be in some kind of a clinical study to do that?
Probably, yeah. I don't think there's a lot of evidence that immune factors are very common in people generally with Tourette syndrome. So the pandas hypothesis is one that's been raised, that is the abnormal response to streptococcal infection. There is a small literature about whether gluten sensitivity might predispose some people to Tourette syndrome or worsen the tics in people with sensitivity. There's not a lot of support for that research, but there may be individuals where that's a sensitivity. Other foods like just sugar in general, some people with Tourette syndrome, some parents have felt their children behave better or have fewer tics when they're avoiding large sugar intake. So, these dietary influences have been reported anecdotally, but they don't seem to be related on a widespread basis. But, if it's your one child who has a particular sensitivity, then it's important. And, most doctors' experiences with Tourette syndrome is that the tics are sensitive to different things in different individuals. So for some people, for some children, they do seem to come out more, say during allergy season, like hay fever or whatever. In other children, they tend to be associated with anxiety more. In others, it's a superimposed illness. If they just have a fever or a cold, their tics will come out. So I think they're, just like all illnesses really, they're individual sensitivities that one needs to think about for each individual patient. Every patient is different to some extent.
Okay, well, since you very nicely brought up pandas in your presentation and have talked about it a little bit here, we do have one question kind of zeroing in on that. So the question has to do with, so a person with TS or ASD, and they have a genetic link, which let me ask a pre-question. TS certainly has a genetic link. Does ASD have that as well?
Yes, it's probably even stronger for ASD, but it looks like, just like Tourette syndrome, it's a complicated genetics. So at one time everyone thought we would find the Tourette syndrome gene, but we're pretty sure now that no such Tourette syndrome gene exists, but rather it is what's called a complex inheritance, meaning that there are susceptibility or risk genes that are inherited, often from both the mother and the father's side. And the more susceptibility or risk genes an individual inherits, the more likely they are to develop Tourette syndrome. And there probably are going to be scores of risk genes, meaning 20, 40, 60, and it just depends on your individual's combination of genes, whether or not they develop Tourette syndrome. The same thing seems to be true of autism. There are a number of genes that in certain individuals, very rarely, single mutations of single genes seem to be associated with autism. But in the vast majority of cases, it's probably just like Tourette syndrome, that it's complex inheritance, meaning that there will be a large number of susceptibility genes, and someone can inherit a whole variety of different combinations of these risk genes, and if you get enough or you get the right combination, then you develop the condition. So that's what complex genetics means. It likely is the way most, if not all, so-called psychiatric or neuropsychiatric disorders are inherited. It's probably the most common form of inheritance for psychiatric and neuropsychiatric conditions.
Okay, so now to the question that was raised about the pandas. So you've got a situation where there potentially is this genetic link, and so you introduce then a virus, bacterial infection like strep or something like that, and the question being posed here is could that the strep infection act as a catalyst in bringing on Tourette, or, you know, or in this case, the autism as well. Now, my understanding of what we've heard is that, you know, you certainly could have, it might bring on tics, but it wouldn't be Tourette, is my understanding, but would you clarify that a little bit?
It's a complicated question, but
and we don't have all night. That's what you're telling me.
yeah, well, let me just say an infection at the wrong time can certainly cause autism. So infections in the womb for a fetus which induces a form of encephalitis, that infant actually has a high risk of being born with some neurodevelopmental problem, which could potentially include autism or potentially Tourette's. We just don't know. But the same thing would be if the fetus is deprived of oxygen for some reason, or some kind of drug or chemical passes through from the pregnant mother to the fetus, can cause abnormal brain development and be manifested by autism or mental retardation or seizures or all sorts of problems. So the question in pandas generally has been, is that the whole story? That can that be the cause of Tourette syndrome? And again, it's a complicated question, but most research at this point does not suggest that an abnormal autoimmune response to streptococcal infection can cause what most people consider to look like Tourette syndrome. The bottom line with pandas, it does look like there are some very rare cases who do have an abnormal response to streptococcal infection, but those cases don't look like your typical patient with Tourette syndrome. Mm-hmm. These are patients who change dramatically from one day to the next. They go from no OCD to 24 hours later having severe, horrible OCD, to one day having no abnormal movements to the next day having lots and lots of tics or other involuntary movements. They have huge personality changes. This is very, very different from Tourette syndrome. That sort of thing just doesn't happen in Tourette syndrome. That's not the natural course of it. Mm-hmm. So it's a different condition. There was a lot of debate initially because the researchers who talked about pandas suggested that the run-of-the-mill child with Tourette syndrome, that they could have their condition caused by streptococcal infection as pandas, but that has really proven to be false. There's just no evidence that that's the case. But there are rare, these dramatic cases that may indeed have this sort of response. It also doesn't look like there's anything specific about strep. You can have the same sort of thing related to other types of infections, like viruses, something called mycoplasma. So the original researchers who described pandas thought it was so important that it was strep, but strep just looks like it's no different from lots of other infections. There's nothing special about strep. So it's, again, a very complicated answer, but it's a complicated situation that's still being clarified.
All right, thank you. It's just about 8:30. I'd just like to touch on one more question. Would you comment, please, or let me say it differently, have you participated in any research which examines the impact of THC on ticks?
It's a timely question, as everyone knows, because we think that soon the use of marijuana cannabis products will become available for individuals with Tourette syndrome in the state of New Jersey. I have not had personal experience, although I am part of an application to the state of New Jersey to test another component of marijuana, which is called CBT, in patients with Tourette syndrome. So we're hoping that that's going to be funded as part of this new project. I have reviewed the literature, the world's literature about the use of marijuana products in Tourette syndrome. It's a very small literature. Most of the work has been done in either Holland or Israel, and there are probably fewer than 25 or 30 patients ever studied totally in the world. But most of the research, at least the very preliminary work, suggests that a number of patients with Tourette syndrome who use increased relaxation that does seem to have a beneficial effect on their tics. When it's been looked at objectively by researchers and when placebo is used, there does not seem to be a clear lessening of the tic severity as measured by certain standard rating scales. So it seems so far, and as I said, it's really, really preliminary information, that there may be some benefit, but perhaps not specifically on tics, but more of the psychological and emotional milieu, in that when people feel more relaxed, more with less anxiety and more at ease, they do have fewer tics. And this is the same kind of thing that's been described in Parkinson's disease, for example, and other neurological conditions. It's not clear that the marijuana products are specific, but when people have movement disorders, when they are relaxed, often their movement disorder is better.
There's no question that anxiety plays quite a role in the whole tic process. So getting something to calm that a little bit would almost seem logical that it would help.
Right, and most of the future work will involve the component I mentioned, CBT, which has, it does not have the effect of causing a high, but is the product that most researchers and patients are interested in, because it seems to be the component of marijuana that's most effective for medical complaints, like chronic pain, anxiety, etc. So if you're using a chemical component that doesn't cause a high, the whole use of this sort of chemical will likely be less controversial, less politically charged, and probably has greater chances of being available more widely with less controversy.
Thank you. I know I said that was the last question, but would you be willing to take one more?
Yeah, sure.
Okay, so this is the last question. Is ASD considered a true medical diagnosis? According to the individual asking the question, they're saying that this is controversial even among the insurance panels. Could you have any comment on that?
No, within the medical field, it's absolutely considered a medical condition. I actually have not heard of problems in the insurance field. For example, clinicians often prescribe behavioral therapies for autism patients, and almost always they are approved by insurance companies if the diagnosis is autism spectrum disorder. If the diagnosis is something else, like depression or anxiety or OCD or emotional disorder or something else, in those situations, the insurance companies often turn down coverage of behavioral therapy. But with a diagnosis of autism, in my experience, they all generally will cover behavioral therapy.
Okay. All right, Dr. Kurlan, thank you. We will definitely wrap it up here. I'm going to turn this back to Kelly for a little bit of stuff that she needs to do at the end. Thank you, everybody, for attending. And Dr. Kurlan, really fine presentation tonight. Thank you.
Thank you, everybody.
Thank you for joining our webinar on TS and autism. There is an exit survey which we need everyone attending to fill out. The webinar blog is open now and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the site. Our next presentation, STOP, an anti-bullying guide for families, schools, and others working with children, will be presented by Dr. Graham Hartke and is scheduled for October 17, 2018. This ends tonight's webinar. Thank you, Dr. Kurlan, for your presentation, and thank you, everyone, for attending. Good night.